Hi, everyone, and welcome back to Damn Parenting, your English speaking parenting podcast from Amsterdam. And as always, we're your hosts, Maren and
Eva.
And today we will tackle a topic that we kept seeing popping up in, you know it, the WhatsApp and the Facebook group. So we thought, let's address it. And I will mention this term one time so everyone knows what we're talking about, and then we will all forget it. But just so you know, when you're faced with it in a medical environment, geriatric pregnancy. It's a tongue tangler. You can already hear it. So we all will forget this term now. And what we're going to talk about today is getting pregnant after 35. That's the whole shebang behind this word or behind this term. And there is a lot of anxiousness and nervousness around this topic, and a lot of, I don't even want to call them facts. There's lots of things that are floating around of that you have to consider, or you have to keep in mind, or you have to be careful of when you become a mother after 35. So we thought, what is this whole information that's floating out there? And we thought, let's bring in, as always, an expert to bring the real facts to the table to get you the information that you need. And we are super delighted that we got to speak to Leonie, who is a gynecologist working at OLVG in Amsterdam, both East and West. And we brought her to the table to address all the things that we heard around this topic. And she was able to sit down with us and go through the list and make sure she's really painting the right picture of what to keep in mind, or what are the things that you might consider when you become a mom after 35. And as always, we try to bring in our personal experience here. So this topic was also important to discuss for Eva because she was a mother over 35 having her first child. Eva, you want to talk a little about your motivation to record this episode?
Yeah, it was a bit of a shock, I think, when I went in to my verloskundige and I was 39 plus 6 days. So I was just one day under 40, and my verloskundige was like, hey, do you want to just pop to the hospital just to get one quick check? I went up and I went into the gynecologist, and the gynecologist started checking me, and basically she then informed me, hey, by the way, we have this new rule in that you can't go past 40 weeks if you're over 40 years of age. And she asked if I wanted to give birth there and then.
And she made it sound like that's like a fact. That's a rule, right? So it wasn't phrased like, this is something you might consider, right?
Honestly, it was just the biggest shock that it wasn't like, if this was something that was discussed with me by my verloskundige in trimester 1 or 2, even 3. Yeah. If there was some kind of communication about this as an option, it would have been like, oh, okay, would have settled with me, and I would have felt very confident to be able to be like, no. But I was so shocked, and I was like, no. Like I wanted a natural birth. I wanted to do everything as natural as possible. The gynecologist lady actually was very lovely. I'm not saying anything bad about it. But she was just saying, this is what it is here in this hospital. And I said, I need to think about it.
Yeah.
And the minute I walked out of the hospital, I rang the verloskundige and I was like, why didn't you tell me this? Like, what is going on here?
Yeah.
And so I've met several mothers over the age of 35 who are very nervous, with, what are different procedures, or is there anything different? And it's a case of, this is why, for me, it was imperative that we got this episode out. Yeah, just to let you know, there's a lot of us out there. And as someone who loves facts, I did look into the rate of people over the age of 35, which is also known as advanced maternal age. But in the Netherlands, 14% of women between 35 and 39 get pregnant with their first pregnancy, and 4% over 40 have their first pregnancy. So we are talking about 17% of the general population in the Netherlands. There is no something specific to each city or anything I couldn't find. But, that's still significant. And so, for me, it was a case of, I really wanted to kind of avoid people's opinions and experiences. And I kind of wanted to say, hey, we just want to get this clarified. We want to be part of an omni-channel of communication about this topic. And considering our last few episodes have really looked at the verloskundige and the kraamzorg and the doula, I thought this was a great timing to stick this one in here as well, in case anyone was, really kind of needing a bit of a comfort or empowerment into this specific topic, to know they're not alone. There's quite a lot of us out there, and hopefully this will put you at ease. You'll enjoy it. First, we want to welcome and thank you so much, Leonie, for joining us. Can you give us a bit of background so that people will know why we are speaking with you?
Yeah, my name is Leonie van Rheenen. I'm a gynecologist. I work in OLVG, East and West, both hospitals. I specialized in obstetrics, so I mainly take care of pregnant women, or I'm active on the labor ward, supervising deliveries. And I'm also active in the samenwerking. All the midwives around and the hospital, they have together a board where we try to work as much together and get all... I'll explain it in Dutch. Dan moeten jullie maar even eruit knippen. Dus we hebben een bestuur van eerste lijnsverloskundigen in het ziekenhuis en de kraamzorg. En daarmee samen proberen we dus gezamenlijke zorg goed op poten te krijgen. En ook gezamenlijke protocollen te maken, gezamenlijke werkwijzes, kwaliteitscyclus. En dat is ook een landelijke verplichting dat je dat hebt als ziekenhuis. En daar zit ik in dat bestuur.
Translate that. So basically, Leonie is actually working together with the board, and it is actually required in the Netherlands that you're actually working together with all different aspects of the birthing community, and that you're actually working together to improve it and to make sure you're hitting the right criteria and conditions, and also looking to further improve maybe that career or profession.
Yeah.
Okay, so today, we're speaking about pregnancy from the age of 35, and many of us are going to know the term geriatric pregnancy. It's one I despise personally, and I know that the medical profession also use advanced maternal age. This topic is basically, we're going to get some insights and knowledge and hopefully some helpful tips for anyone who is looking to get pregnant or are pregnant and are about to give birth. So Leonie, could you help us understand what are specific preconception health measures or screenings that women should consider before getting pregnant with their advanced maternal age?
It's not so much based on advanced maternal age. It's for any women good if they decide on getting pregnant to in general have a healthy lifestyle. So refrain from smoking, drugs, alcohol, and start taking folic acid. And it's also good for your general health, but also for a start of a pregnancy to be on a healthy weight. So that's for a lot of people quite difficult, but also for your fertility and also for your pregnancy, it's good if you start out on a healthy weight, especially not too heavy. And another aspect of getting pregnant is try to be stable mentally. It asks a lot of your emotions already to go through the whole change of pregnancy and having a baby. So if there's any specific vulnerability in your psychological life until so far, it's good to pay some attention to that. If you're having a stable relation, that you feel like you're mentally prepared to have a baby. But in general, for elder women, I would say if you decide to get pregnant, do it as soon as possible, because it will make your chances of becoming pregnant. Having a pregnancy that goes on past for the risk of miscarriage is good to have your age is not too high. So if you think I'm not healthy enough, or I don't know my partner long enough, or my housing is not stable enough, maybe just organize all of that within the 9 months of pregnancy and get pregnant as soon as possible.
Okay.
So get your life together and then get a baby.
If you want to have a baby, go for it and get your life together in 9 months' time.
That's a deadline.
If you postpone it, you make your chances less.
Right. Not too demanding there. Can you actually give us some key differences or considerations of pregnancy and childbirth between the average age of say someone doing this in their early 30s versus in their late 30s or early 40s?
So it's all about the placenta. So the placenta grows in pregnancy and you don't really have any control over that. So you cannot make your placenta big or good, and the vessels in your placenta, they have to adapt to the pregnancy. So they have to be wider and wider when the baby grows. So the baby gets enough blood flow to have enough oxygen and enough feeding. And on a higher age, we know that your vessels are not as good as at a younger age. So also the vessels in the placenta are not as good as at a younger age. And then this demanding of the vessels need to be big enough to increase the blood flow for oxygen and food until 41 or 42 weeks. And that system is not always well developed when you're a bit older. You can't really influence it. We try to influence it by advising to take aspirin, because we know that improves the growth of the vessels in the placenta. And we can't really measure it very, very well. So if you say, well, I'm halfway through my pregnancy, I want exactly to know if my vessels are capable of keeping my baby healthy until 42 weeks, because then I can wait, or keeping my baby in until 38 weeks. We don't really have good ways of measuring it. We have things a bit that maybe can help us a bit. And if the vessels are not good and there is a growth restriction of the baby, or as a mother you develop hypertension or preeclampsia, then we know there's something wrong with the vessels. But sort of in between, when everything seems to be going well, then you don't really know if you're in this right adaptation until the end of pregnancy.
You would still take the aspirin just as a precaution, and it wouldn't do anything bad, I assume, even if, let's say, everything was perfect anyway, but there is no risk taking.
No, so that internationally we think that taking aspirin is safe enough to say also for low risk women to improve the placenta, it's good if you take it. And there is a whole protocol of which people we should advise aspirin. And then you have the first baby at a higher age are two minor criteria that you need to advise somebody aspirin, and you have some criteria that you only have to have one to already advise aspirin, like having a preeclampsia in a previous pregnancy, or having diabetes, or having hypertension outside of pregnancy. Then you say right away, take one. Yeah.
So if we are looking then at like supplements like aspirin or whatever, is there a role of the prenatal vitamins and supplements and any additional considerations? Because you spoke earlier about folic acid, but is there any additional considerations for first-time mothers?
Folic acid, we advise for all pregnant women to prevent neurological problems in the baby. And you have the vitamin D that we advise for all pregnant lactating women and children under the age of 4. And vitamin D you mainly make by the sun, but apparently in the Netherlands, a lot of people are vitamin D deficient. So that's in general, but I don't have an advice for specific older moms to take any other things than what we advise in general. To walk around with really vitamin deficiencies, you have to take care quite bad of yourself. And I think in the population of expat mothers in Amsterdam in general, they have quite a high health literacy. They know how to take care of themselves. They eat their vegetables and their fruits. Yeah, the general advice is if you prepare your meals mainly yourself, so from fresh ingredients, you don't have a vitamin deficiency. So I don't think you have to really focus on other supplements. A lot of things that you can buy over the counter are also not harmful. So if you think I need something else, you can buy it. But be aware that, of course, people that tell you to take vitamins might have an interest in selling them because they earn from it. So be a bit critical about their advice. And the other thing is that in the first trimester, if you already experience nauseousness or vomiting, vitamin tablets are the last one you like to swallow. And don't feel guilty about it. It will be better somewhere else in pregnancy.
Good to know. So are there any specific like prenatal tests or screenings that are particularly important for these advanced maternal aged mothers?
Luckily, we left the protocol where we only did prenatal screening tests in mothers over 35. So we offer all women in the Netherlands the same tests. And at the moment, that's the NIP test. The NIP test where you look for the syndromes, Down syndrome, Edwards syndrome, Patau syndrome in the blood. And we do the normal structural anomaly scans. And there's not something extra that we do for elder women.
It's kind of good to know. So we spoke earlier about how the blood flow is basically an issue then when we're talking about any conditions that actually can happen with the fetus and any potential risks. When we're talking about all of this, like as an international family, we're going to be here and going to be experiencing these meetings with our verloskundiges or our gynecologists. Do you know if there's any kind of trace of significant genetic counseling for mothers? Like, is there any kind of way that somewhere we can go to talk to people about these kind of potential risks for mothers to actually go to be able to have somewhere to talk to about anything that might come up? Is there any service in the Netherlands that actually provides like the information where they can go find this information and have someone to speak to about it?
As an older mother, you have a higher risk for miscarriages and also a higher risk that your baby has Down syndrome or any other trisomy. And we can test that with the NIP, but of course it's quite unlucky if you are finally pregnant and you want to abort this pregnancy because the abnormality that is there. You don't have any options to prevent it from happening. Every midwife or hospital or gynecologist will tell you what kind of tests you can do. If you really need specific counseling for anything that runs in your family, or you want to have a generic screening for inheritable diseases, you need to go to a doctor that's called a klinisch geneticus. They know all about the genes, and that there is an option that they test couples before even getting pregnant on carrying any genetic abnormalities. But they're also not specific for elder women. You can do that as any women. And the clinical genetic doctors, they are in academic medical center. They're not in all the hospitals around in Amsterdam. They have a website where they explain it. I think it's in Dutch. I'll give it to you that you can add it to the podcast.
Thank you. I think that's quite a lot of down talking there of quite a hard topic.
I also think it's good to hear that it's not, like you said, this is not something that is preventable. It happens.
That's a bit the same with your placenta.
Yeah.
Women with a high, good education, a good job, we like to have everything in control. But a lot of things that's happening in your belly is not in your control. It doesn't feel maybe very nice because you cannot influence it. But on the other hand, you've done nothing wrong when you have preeclampsia. You just have preeclampsia. And yeah, your body just made it that way. And same for a miscarriage. People love to find a reason why they have a miscarriage. And of course, it's nice to have a reason because then you can prevent having a miscarriage. But it's not because you drank coffee or you went running in the Vondelpark.
Yeah, this is, I think, a whole other episode in itself, because I do feel like the guilt. Yeah, the guilt that comes with that, I think, is absolutely exponential. So thank you for mentioning that.
Yeah, we'll fill in another episode with somebody else talking about these kind of feelings. Yeah.
So when it comes to the birthing, as it were, is there any difference between, like, say, in your 30s or in your 40s with the birthing options that are available?
No, so the options there are the same, and the system, and I think you had also an episode on the Dutch system where you try to have the low risk women with the midwife and more mid risk or high risk women in the hospital. And of course, this level of risk or what you demand for birth can change during the birth, so that you switch from the midwife to the hospital, maybe when you want any painkillers or when there's a need for an induction. On beforehand, it's not so that we say you have to do this or that as a woman of advanced maternal age. Then there's the thing about the induction of labor at term. I think that was one of the big questions of this podcast. Why is it advised and based on which information? It also has to do with this placenta, what I earlier talked about. So in general, we know that placenta can be sort of at the end of their limit at 42 weeks. And then the risk of having a baby with birth asphyxia, so having not enough oxygen supply, or that the baby gets in distress during labor and then has meconium stained liquor or has abnormal pattern of the heartbeat or even dies during labor, that all increases after 42 weeks. And there's this span between 41 and 42 weeks where we have a lot of debate about it, but for the whole population, it increases after 41 weeks, all those risks. And for older women, because we know that their placentas are probably at a sooner time at their edge of spreading the vessels wide enough to get all the oxygen and the food, we say we preferably induce you at 40 weeks. And all the things we know about it is from observational data. So then you have a cohort of people being over 40 and you see these increased risks of getting hypertension, getting babies that need a C-section because they have their fetal distress during birth. And then we say, okay, we induce earlier. But if you really want to know if inducing earlier works, you should also have this cohort where we just go with the flow compared to the cohort where we induced and then see if there are the differences. And that research doesn't exist. And I think it's also too difficult to do it or to make it. Also in the international guidelines, it says for older women induce earlier. And that's also what we say. OLVG East and West say the same. Of course, what you would like to have an individual advice, like for you as your age, maybe your obstetric history, your general health, or maybe for this baby that we do certain checks with the baby. It can be 40 weeks or it can be 40 plus 3 or 41 or 42. But these kind of tests, they don't exist. So in these observational data, there's all kind of people there. Yeah, it's difficult to really say what to do in the individual patient or the individual woman. I think when you have a obstetric history without any abnormalities, then we know that your body is quite capable of building good placentas and delivering easy. So then maybe we shouldn't be so focused so much on this age of 40. Whereas if people have an unplanned pregnancy, in maybe an unhealthy body, they have maybe more risks. But we know with the first pregnancy that all the adaptation of your body is already difficult. So at the first pregnancies, also with younger women, you see the most hypertension in pregnancy, preeclampsia. It's not in the second. So if you combine the older age with the first baby, then I think we're quite well to advise you to be induced earlier. You don't have to be induced. It's always, there's no law that says you have to do this or you have to do that. We as doctors and midwives, we can give you the information we have. We can give you the options you have and you can choose. And you can also decline any medical intervention if you don't want to do it. And even if you want to, let's say, never go to a midwife and give birth behind a tree, you're also you're not against the law. So we can give medical advice. The law tells us what to do, give you an advice, tell you the pros and cons, tell you the options, and the law doesn't tell you what to do. On the other hand, if you as a woman say, I want to have this cesarean section because this is my reason why I want to never deliver vaginally, we can say as a doctor, you cannot ask us to do everything you want. We need to debate with you whether it's necessary, why you ask this, what your options are. So the Dutch law says for healthcare, tells people that work in healthcare how they should counsel a patient and how they should let a patient choose what their preferred medical intervention is. So a sort of sidestep from being induced at 40 weeks.
I guess that also goes then in the exact opposite direction, because I was like thinking in my head, oh, so you should be induced and it's like kind of the protocol. But then I thought, oh, so women over 35 don't really have the choice of a home birth or don't really have the choice of like a different setting other than the hospital. Because I guess if you have to be induced, you're not going to be sent home. You're like, all right.
Yeah, then you're out of your midwifery practice and you cannot have a home birth or a bevalcentrum birth. You have to be informed about that. That's the medical advice. Yeah. And then you choose yourself.
Yeah.
So that's actually the main reason for this actual episode, is because I was over 35, not going to give my real age, but I was over 35. And yeah, the day before I was 40 weeks, I literally was told by my verloskundige, hey, let's just go for an extra check. Please go to OLVG. And I did. And the gynecologist said, did you know we have this new, I think it was only brought in 2020. And they said, there's this new rule where we don't want you to go past 40 weeks. And I was absolutely shocked and I couldn't believe it. And I didn't feel pressured that I had to be induced there and then, but it was just such a, like, no one told me this, but it's also because it was new. But they were very supportive. But then, yes, I had then been transferred into then the medical side of things where they were like, well, now you're going to go there. And I was allowed 8 days grace then thereafter, thankfully. But this is the thing for me. This is why it was so important for this episode, because I want people to know this and to be empowered. And I'm so thankful for you to be able to explain that people still have their rights. And it's not like a law, as you say, that people have to do, but it's something that you must inform them of and give them counseling of. So
yeah, and I think one of the things in OLVG we have to improve then is to be sure that different caregivers give the same information, so that you maybe already heard from your midwife. And I mean, you don't have to hear it already at 12 weeks, because probably at 12 weeks you're not considering where to give birth, but somewhere along the way you start making a birthing plan or you start doing a pregnancy course. And then, hey, you also have the option of being induced earlier, and we actually advise you to be induced earlier, and then that you can search for enough information to make a good decision.
Yeah, as I said, it's the whole reason for this specific episode in itself. Talking about the delivery as well, can we just look about the pain management options? Are there any differences, or is there any difference between giving birth in your 20s versus 40s, like when it comes to any pain related management skills?
Yeah, it's very individual how the birth goes. Also from how your birth goes, is a lot of things are out of your control. Of course, some things are in your control. You can do your preparation, physical preparation, have your knowledge, do your mental preparation, have your partner be a bit involved, that he or she can also give you enough support when you need it. But a lot of things are out of your hands. I mean, the muscle of your uterus it's like, yeah, you cannot tell the muscle of your uterus, whoa, I now want you to contract very hard because I want to push this baby out easy. So there's something in there that you should also be prepared for, to let go of your control. And yeah, but we experience all kind of things. So people in their 20s, they might have from the nature is more on their side to have an easy birth, but maybe they don't have paths where they chose to become pregnant or chose to give birth in a specific way. They just ended up being pregnant, or it was just part of the deal when you married and the next year you're pregnant and you have a baby, without having all the specific decisions that a lot of times older mothers, they're much more in a sort of path that they choose to be pregnant and choose to give birth in a certain way, and they prepare themselves. And I think mothers that listen to this podcast probably are also quite preparing well for the delivery, otherwise they wouldn't listen to this podcast. So it's very different in what people experience during a birth and whether they want painkillers or not.
And then thereafter, when we're talking about the postpartum, is there any difference when it looks at postpartum for someone over the age of 35 and into their 40s, and any health concerns that we should be aware of?
Well, then your pregnancy and delivery is sort of your extreme stress test. So if you go through it very well, then probably you'll be a healthy grandmother at some point in time. If you do get hypertension or diabetes, so high blood sugars, then probably that's one of your vulnerabilities on later life, maybe post-menopause. You also develop hypertension or diabetes. And of course, if your lifestyle stays healthy and you keep on moving, then you diminish your risks. But then that's something what a general practitioner at maybe over the age of 50 at some point in life can test again. I'm not sure about breastfeeding. This was before this podcast. I thought, is it for elder women more difficult to breastfeed? I don't know. I don't think maybe we don't even have this information. In general, it is a bit of struggle to start breastfeeding with first baby, and then with the second you have your knowledge and it goes a bit easier. But if it's more difficult when you're older, I don't know.
Yeah, everything's unknown. Everything is for unique, I guess, to be honest. When it comes to everyone is unique in their own.
Of course, when you're young, you can do just anything. I mean, a lot of times young women they can easily adapt to maybe sleep deprivation or having all kind of a body that needs to sort of fall back in place. When you're older, everything goes a bit slower. So it might be that it's also the postpartum period is a bit harder. I don't have specific data on that.
We'll have if it was a man giving birth, we would have all this data, but obviously it's not really for us right now. But
so there's no, especially when I'm thinking of birth injuries, also in C-sections, is there any difference within the healing or the time after that women who are younger have an easier or harder time with specific healing aspects, especially when it comes to C-section, or older than the other way also?
Thromboembolism, so having a blood clot somewhere, and that risk also gets higher when you have had a C-section, any surgery.
That's when you get to wear those beautiful socks.
Yeah, but now, we stopped the socks again. It's always something. there's always something old and new. Maybe the socks come back at some point in time. But now, for a lot of women, we advise them to take a bit longer their anticoagulant medication that we give in the hospital. You get the injection for anticoagulant medication after a C-section, and some women we advise to take home as well. But we didn't put maternal age. It's more for it's more all the complications you had during the pregnancy that give you a higher risk for having a thromboembolism. No, I don't think there are specific aspects of healing after C-section or after vaginal birth from younger or older age.
Are there any new changes expected in the Netherlands in hospitals or anything else? Is there any new updates coming out in the next year that you might be able to share?
Well, the biggest challenge at the moment is the capacity problem. So having not enough nurses around to make sure every woman in Amsterdam has birth in a hospital in Amsterdam. What is internationally really upcoming, and probably, I don't know, next year, but in the next years, is trying to do much more of a risk assessment in the beginning of pregnancy. So some values with the ultrasound, some hormones in your blood, some maybe blood flow measurements somewhere that you can really say, okay, your risk for preeclampsia is on that level and your risk for growth restriction is on that level, and then try to make a pregnancy checkups according to that risk. It is always difficult because then does it help you to know in the beginning of pregnancy that you're on a high risk for preeclampsia? Does it make you feel better? I don't know. And on the other hand, if we don't really offer interventions, if we cannot say, oh, well, with the aspirin, you go from 80% to 20%, is it then ethical to tell them? But I think we're going that way of doing much more of a risk assessment. At least it helps us for doing all these general advices of having an ultrasound at that week and an induction at that week, maybe to make the groups where you advise these things a bit smaller, and that you have specific care for specific women at a good timing. Yeah.
So it's a unique, basically everyone's not going to have the same usual path. They actually have something tailored for them.
Yeah, and hopefully when we tailor it, then also some women can have less checkups or can have less stress during pregnancy. Yeah, we need to see that in the future if that's really that way.
That's good to hear. Yeah, I mean, I think we covered everything. I'm definitely satisfied. So thank you so much for sharing all this, because for me, it was I felt really different from the group of moms that I was in with Maren. Like, I was experiencing something that none of them were experiencing. I was like, what the hell? Like, why am I being told to induce when no one else was? So yeah.
But it's good to hear that they general advice, because these things are known. So it's coming from a place where it's like, we want to make sure you can get the best possible outcome. So that's good to hear that it's really, at the end of the day, you say, well, these can be risks, but so we try to do them preventively. But at the same time, I heard you saying you can enjoy your pregnancy as a 20-year-old, as a 40-year-old, like just keep, be with you. Just make sure you're relaxed, you're in a good state, and that will automatically then obviously help with other things. And not become a self-fulfilling prophecy where you have all these, this is a risk, this is a risk. And then of course in your head, it becomes a much bigger topic than it has to be. So I think this was the biggest outcome that I took away, you saying, chill out, get your stuff together, just do whatever you do normally. We'll have an eye on it. And if something comes up, we can address it, but you don't need to stress out just because you're 35. And I think that was good to hear.
35 and above, but yeah.
Yeah, especially far above 35. Like, pregnancy is not a condition. Pregnancy is not an illness. You need to put it that way. Pregnancy is not an illness.
Perfect.
Well, thank you so much, Leonie. I greatly appreciate your voice of wisdom and knowledge and insight. And for anyone else listening out there, we will have a lot of links probably in the show notes that Leonie will share with us, and that we can make sure that you can look up and read up on any of the topics that she's covered.
Yeah, and Leonie is also one of the specialists for breech birthing. So we will definitely have her back on that topic, because you already told us she can talk weeks and weeks and weeks about this topic. So we will definitely have her on for another episode on this topic, in case anyone is also questioning what's possible there.
So thank you very much, Leonie.
What was your biggest relief and takeaway from this?
Yeah, I mean, to be honest, I just hope this is actually going to get into the ears of those who really need it, and the fact is, there's nothing different out there. And the biggest key learning that Leonie was actually telling us was, it's really all about research, and it's really all about the facts, and it's really about the placenta, this extra organ us women are able to create, which is phenomenal. But it's really just about ensuring that the blood vessels created are healthy, and that the placenta can actually last and, help you throughout your whole pregnancy. And I myself had to go on aspirin every single day, which was so bizarre about, because I don't normally take any painkillers or anything anyway in general. But I was explained the process. And again, hopefully this will also ease up anyone's thoughts. The aspirin is literally only to help with ensuring your placenta is as healthy as it can be, and to ensure that you will achieve a great birth due date area.
And what I also find reassuring, that's also the questions that I asked, was it doesn't do anything harmful, even if you wouldn't technically need it. So they're not making it worse. If it don't need it, then it's just an extra, but it's not going to harm you. So that was, I think, the main information for me to take away, that because she said you can't test the placenta, there's no way to look at it and see and then determine if it's needed or not. So they give it pretty cautiously. And then at the same time, if your placenta is healthy or the best it can be, it's not going to do anything weird, or it's not going to harm you. So I think that was reassuring to know that I'll take it, and it might in the best case help, and it might do nothing. And that's also a good outcome, I guess. And that was really interesting. And I could really understand the reasoning and the logic behind this, because it makes sense to me that, of course, you get older and then your blood vessels, they change as well. And that makes then also sense for the placenta. So that was a logical explanation that I could follow. And that was something that I hadn't thought of.
I don't think any one of us would have actually thought of that, because it really is a case of the Vlaskundige just says, oh, hey, and by the way, you're going to start taking aspirin. And it was like, why?
Yeah. And also good for me to hear was really what she said, that one thing, first of all, everything is a choice. They're there to educate you. They're required to give you the information. At the end of the day, the decision lies with you. And also one thing that she mentioned at the end was that the international guidelines or the international discussions are that we have these guidelines, however, you need to look at your individual patient and then you can apply them or not. And that was, I think, a good movement of, here are the general rules, but let's not forget, we're not dealing with machines, we are dealing with humans, and your patients. So I think it's good to give responsibility back with this to your gynecologist or to your midwife to assess an individual treatment. And I think that is needed in so many fields within pregnancy. I mean, I'm only addressing the whole weight issue and BMI and all that. That was really good for me to hear, that it is coming to tailored treatment more and more and more.
Yeah, it's a very holistic kind of approach now. And it's actually great to hear a doctor from a hospital who, as you say, is not treating you as a number or just a patient or whatever. It's just a case of, okay, who are you? What is your background? How's your pregnancy been so far? And that was really good for me. But for anyone listening, the one thing I definitely want to say for anyone who's actually 35 and above, talk to your Verloskundige and ask them about this. Make sure that you're not shocked into anything. We hope this is going to help you understand the whole idea. And now you also know that you have the option if you want to actually give birth at 40 weeks, or if you also want to do exactly what I did and try and wait as long as I possibly can. But exactly as she said, it's about empowering me with the knowledge that it's a case of, look, this is based on facts. So I didn't wait till 42 weeks, but I did pass 41 weeks. Thing was fine for me, thankfully.
Yeah, so hopefully that helped you get more education around this topic and then make a informed decision, or put this into your toolbox of then things that will help you to make a decision on your own or with your partner or with your midwife together. And if you find this episode helpful, then as always, please make sure that you share it, like it, and support us on Spotify, Apple Podcasts, and on Instagram. This
and
is how
YouTube.
we can grow. And YouTube, exactly. Now we're also on YouTube. Not with our faces, don't worry, but with our beautiful voices coming into your ear, giving you all the information you need around pregnancy and parenthood as an expat here in Amsterdam and the Netherlands. And because we want to keep this going, we need your support. So as I said, please make sure to give us a like on Spotify, on Instagram, give us a follow, and give us 5 incredible shining stars so we putting the word out there can continue. And with that, we'll say goodbye, and we will hear you on the next episode, which is coming out every Wednesday. So make sure you click the bell on your Spotify and Apple account that you get notified when we will be back with the next topic for you.
Bye.